Welcome, everyone. My name is Allison Drew. I am the program coordinator for the Regional Autism Assistance Program. I would like to welcome you to the Autism Basics Webinar Series featuring Dr. Kelly Pelzel, and this session is on treating dangerous behavior. And this is a friendly reminder that certificates of attendance and foster parent training credit are available for the live sessions only. And now I'm happy to introduce Dr. Kelly Pelzel. Dr. Kelly Pelzel is a licensed psychologist and clinical assistant professor working in the University of Iowa Stead Family Children's Hospital Child and Adolescent Psychiatry Division. She received her BA from the University of Northern Iowa, and Dr. Pelzel received her PhD from the University of Utah. She completed her pre-doctoral psychology internship at Primary Children's Hospital in Salt Lake City. Dr. Kelly Pelzel completed a leadership education in neurodevelopmental and related disabilities postdoctoral fellowship with the University of Iowa Stead Family Children's Hospital Center for Disabilities and Development. She provides assessment and treatment services. Dr. Kelly Pelzel also serves as the clinical coordinator for the University of Iowa Stead Family Children's Hospital Autism Center and the psychology consultant for Iowa's Regional Autism Assistance Program. And as we go through this session, questions can be typed into the question box at the bottom of your screen, and Dr. Kelly Pelzel will respond to them at the end of the session as time allows. Now I will turn it over to you, Dr. Kelly Pelzel.
Thanks. Thanks for joining. Welcome back if you're coming back from our first 2 weeks. And I promised last week at the end that we would talk a bit today about treating dangerous behavior. Last week we focused a lot on different treatments, different interventions, but I skipped over treatments for dangerous behavior because, well, for a number of reasons, but we'll talk about here. But it's a pretty big area of treatment and a pretty important area of treatment if it is something a family is experiencing. So just a little overview of kind of how things will go across the hour. I'll just provide some general information about dangerous behavior and my thoughts on what belongs in that category. And then we'll talk about behavioral approaches to treatment, and those particular that are focused on understanding the function of a behavior and keeping that function of behavior in mind when you design the intervention. And then we'll talk about parent-child interaction therapy, PCIT, because it's a pretty popular treatment in Iowa and is a little bit different than a function-based approach, but also has some good research behind it. So we'll spend some time talking about that as well. And then we will talk about just a little bit on safety and in particular about wandering and elopement, because this is can be a very dangerous thing and is certainly an important thing for everyone to be thinking about and thinking about how to handle as a family, as a community, and keeping everyone safe. Before I start, a couple things that are important to keep in mind that I feel like I need to disclose. One is throughout my time at University of Iowa, I've been involved in research on function-based interventions. So I've worked with some of the behavioral psychologists who look at functional assessment and functional communication training, which we'll talk about later. While I'm not trained in the delivery of that as an intervention, I've certainly been associated with their research on that subject. And then secondly is I do offer parent-child interaction therapy, PCIT, as a clinical service to families, both for young kids with autism as well as without autism. And so I have a little bias there as well, because I do really think it's a good intervention in many ways. Okay, let's start by talking just a little bit about dangerous behavior. And as I've given this webinar over the years, I've changed the name of this particular module probably more than the others, because I really want to try to make it clear to folks listening the kinds of behaviors that I consider an important thing to be thinking about in terms of treatment. So there are lots of atypical behaviors that individuals with autism can show as part of the diagnostic presentation of the disorder. And those are not the kinds of things we're talking about here. We're talking about things that can hurt others or hurt the individual themselves. So I've kind of boiled it down to these four things, at least in my mind, of what I think constitutes dangerous behavior. So physical aggression towards other people, self-injury, so things like a child hitting their own head against something or hitting their own head with their hand or fist or biting themselves, that kind of self-injury. And destructive behavior. So things like breaking items or throwing items. Again, because I think that can result in harm to self or others, perhaps not intentionally, but can. And then severe non-compliance. And again, not just the typical tantrum no, but something where it's going to potentially lead to something dangerous like elopement. So again, behaviors that really have the potential to result in harm to oneself, to others, and also are interfering with daily functioning in at least one setting, potentially more than one setting. Okay. I'll turn my video back on again at the end for questions and answers. And so we focus on treating dangerous behavior because it's observed at a substantially higher rate in children with autism than in typically developing kids the same age. And that's been well established in the research literature for some time. And dangerous behavior really is a stressful thing for parents and for families. And further, what they've looked at is, this totally makes sense to me that when you're under stress, you're not at your best, right? And so that stress that the behavior is causing is affecting how well parents can parent. And if they're not parenting at their best, then of course that can exacerbate that behavior that's of concern. So there's a potential for a cycle there between the stress and the behavior. There's a lot of disparities in who can access interventions based on what's going on behaviorally for the child. So if a child is demonstrating a lot of dangerous behavior, oftentimes that's going to limit their ability to participate in other treatments, like the kinds of things I talked about last week for working on skills that have been identified by the individual or the family that they want to be working on. And whether that's, them being, formally excluded from something or, just, going and participating, but having to do so in a really limited way because working on managing the dangerous behavior. Oftentimes it's getting that dangerous behavior where it's not so disruptive in order to be able to do some of those other interventions. And I just want to say, I also talk about it because I do think we need more options, both in terms of like, hey, things that people can study and find out that work and disseminate. but also, just in terms of what we already know works, it being available here in Iowa and other places for families. So when you look at the research literature, there's basically kind of three types of treatments that we know work for dangerous behavior. One is behavior therapy, and that's what I'm going to mostly be talking about today. A second category is parent training. So this is basically teaching and sometimes coaching parents on those techniques from behavior therapy. And then the third category is medication, so psychoactive medications. And specifically, and I may have mentioned these last week as well, these are what are common and what we know in the research literature may work well for treating some dangerous behaviors. So Risperdal and Abilify have been shown effective for treating irritability, aggression, and self-injury. And my understanding is they are the only medications that are basically FDA approved for specifically for autism. Now, individuals with autism take all kinds of medications, but when you look at like, hey, what's have FDA approval for autism, the antipsychotics are what's going to be listed. With those, of course, though, there can be side effects, and one that is particularly concerning that people need to keep in mind is weight gain on those medications. Another class of medications that we know are effective are stimulant medications like methylphenidate for ADHD symptoms. Oftentimes there's other medications that are used as well for ADHD symptoms like Strattera and guanfacine and clonidine, and they can be effective as well. And again, we're just saying kind of on average, so every individual is different in how they're going to respond to medications and what's going to work well. But as a class, methylphenidate has good research evidence. Now, that is not to say that individuals with ADHD symptoms, engage in dangerous behavior. But in terms of like impulsivity, and working on impulsivity and hyperactivity, these medications may help with the picture. And then lastly, if there's anxiety or depression that may be underlying some of that dangerous behavior. So for example, a really anxious child who engages in a lot of dangerous behavior to escape things they're anxious about. Fluoxetine may be effective for that. And then just a note here, there's little evidence out there for insight-oriented psychotherapies. So like your traditional, more relational talk therapies. I'm not talking about CBT, but more like psychodynamic, psychoanalytic approaches. Or play therapy. So traditional individual play therapy. There's little evidence that those are going to reduce dangerous behaviors in children with autism. So now I'm going to turn and talk about behavior therapy, and I'm going to kind of meld a little bit between behavior therapy and parent training, because I've been lucky to work with a lot of individuals who have blended those over time in terms of how they approach things and the research that they do. So when we talk about behavior therapy, it can be something that's just delivered by a provider or an educator, the interventionist, and not involving the parent. And that is effective. But there's also behavior therapy where you can really involve the caregiver, a parent, or other family member, or lots of family members into the treatment. And sometimes when you do that, it's called parent mediated or parent facilitated. Lots of terms there for it. But the idea that you're teaching and coaching a parent or other caregiver on what to do in terms of behavior therapy. And there's lots of reasons to take this approach. Even though, a caregiver is probably not going to be quite as effective as delivering it at first, because, they don't know that they're learning the technique, they don't already know it. And that takes some time. But you get a lot of really good things out of it. I think most importantly that a parent knows their child way better than you as a provider. So when you're working together with them and kind of collaborating, they can let you know how this technique or this thing that you want to do in terms of the treatment, how that's going to go with their child, and how to make it a little bit more tailored and individualized for what's going on with their particular child. So, you can kind of come in with your general idea and, some of that's based on observation, but they're with the child all of the time. So they can really shore that up for you. And when you teach parents how to do things, it increases the number of intervention hours you're getting. So, if I'm teaching and coaching a parent and using my, therapy hour for that each week, then they can go home and practice that with their child throughout the week. So just the number of intervention hours goes way, way up when we're involving parents. And also, they're doing it outside of a clinic room. They're doing it in their homes, in the community. And that's going to allow for greater generalization of the skills. A lot of behavior therapists can get things looking really, really good in the clinic setting. But that generalization piece of like how it looks at the grocery store, playing with their sibling at home, that's the trick. And so I think as we could fold parents in, we can start to get there in terms of the generalization. Okay, so when we do a behavioral approach, um, and this is getting maybe back to like a psychology 101 kind of class. So uh, uh, sorry for that. But it really is based on the operant model. So thinking back to like Skinner, and the idea is that there are things that come before a behavior. And then there's the behavioral response, like hitting, kicking, appropriate behavior, whatever the child's doing, that's the behavior. And then the consequence. So what follows that behavioral response? So we'll talk a lot about antecedents and consequences today. I won't actually be saying too much about the actual behaviors. While they're important to know and important to think about in terms of safety when you're treating them, and what's going to work well in terms of how you have your space and materials set up, that sort of thing. This model cares a little less about like, hey, is it kicking or is it biting themselves? It's more about what's coming before and what's coming after. And sometimes when we're thinking about what's coming before, we're thinking about kind of, hey, what's like triggering this behavior? So that's one way to think about the antecedent. But another way to think about it too is what you're setting up prior to any behavior occurring, and things that you're doing to try to keep the behavior from occurring in the first place. So like an example of this would be transition cues. That's a pretty common antecedent strategy that is used by parents and teachers. And a lot of times this is real simple. It just looks like a verbal prompt of like, okay, 2 minutes, and then we're gonna be going, or you have 2 more minutes for this video, and then I'm turning off the iPad, right? So that's that verbal warning. It can also be something verbal that becomes a routine, and like the cleanup song, right? Is a verbal routine that lets kids know we're going to transition to a new activity. Um, Transition cues can also be things like we talked about last week, like those visual schedules, visual timers to let kids know what's coming next and when it's time to move on. It can be nonverbal cues like gestures or movement, like we're all going to stand up and line up by the door. And that means we're going to be transitioning to a different space in the school. Or it can be audio cues like music or buzzers to let kids know, oh, okay, time's up on this thing. And now I'm gonna move on to this new activity. So just a few examples there. So yes, sometimes we're thinking about it in terms of those triggers and things, but oftentimes we're also thinking about what we're putting in place for the child to do well behaviorally in the setting. Okay. And again, back to kind of Psych 101 things. When we're thinking about consequences, we're thinking about reinforcement, and we're thinking about punishment. And with both of these things, we're thinking about whether we're adding something to the situation or taking away something from the situation in order to either increase what we want to see more of or decrease what we want to see less of over time. And there'll be no quiz at the end of this webinar, but kind of something to think about here is both with punishment and with reinforcement with rewards, it can be adding something or taking something away. And so in a lot of ways, when you talk about these things, they can be kind of flip sides of the same coin. So you might be talking about increasing appropriate behavior by rewarding a child with more iPad time, right? So that'd be positive reinforcement. Or you could be talking about taking away the iPad when they engage in inappropriate behavior. So it could be, a negative punishment. So it's a little bit kind of how you frame things in terms of appropriate behavior or inappropriate behavior, and if you're adding to or taking away. And when we're starting to sort all of this out and what we think is kind of going on with situations where children are engaging in dangerous behavior, we try to get real systematic about this. And there's a couple of ways that we can do this. Oftentimes it starts with a more indirect way of assessing this. So what this means is rather than observing it directly, we're talking to people and we're getting information from people, teachers, parents, others that are around the child, to try to get a sense of what those antecedents and what those rewards are for a dangerous behavior. So sometimes this is parents or teachers charting things for us, like, hey, what was going on right before this behavior happened, and then what happened after it occurred. And sometimes it's even like rating scales and things that people fill out to this effect. It's definitely a lot less expensive as a method. And it's really actually probably your only method when you're looking at dangerous behaviors that, while concerning, don't happen very often. So it's like hard to catch it through direct observation because maybe it only happens, once a week or something, but it's really, really concerning when it happens. Some cons to indirect methods is that you're really depending on people's recollections of what has happened. And we all like to think we have good memories, but people's memories are not that good. And when people are filling things out for you, sometimes they think you want something way different than what you actually want as the interventionist, the information you actually need in order to design a good treatment for the child. So I've had parents like, um, you know, make these lovely charts for me sometimes, but they contain like these big descriptives of, like, for example, the actual behavior. And while I need to know a little bit about the actual behavior, like I don't actually care that much about what the tantrum looked like. Whether it involved hitting or kicking or, going after a sibling or something like that. Like that's less important to me than what happened right before and what happened afterwards. Okay. And then the more expensive, but sometimes necessary method is to observe behavior directly. And the most kind of elaborate version of this is called a standard functional analysis. And this is where a provider is going to get real systematic about looking at those antecedents and consequences and kind of try to turn them on and off one at a time to figure out what makes the behavior start and what makes the behavior continue. And what they're oftentimes looking at is three different social functions, three different things that they think are making behavior start and continue. One is attention, one is tangible, so like access to things. And then the third function is escape from things or activities that are aversive to an individual. Now, on occasion, there are behaviors that are considered non-social or sometimes it's called automatic. So these are things that, if you test them out on one of these standard functional analyses, you're not going to see them maintained by attention or stuff or getting out, avoiding things. They're going to happen regardless because there's something kind of inherent that is like internal and rewarding to the child. So, for example, there are kids who engage in some self-injurious behavior that is non-social or automatic, and the idea with that is that there's something about that sensation that's reinforcing to them, and rather than something externally that's reinforcing about it. And that's not to say those things can't be treated, but I'm not going to really touch on that today because it's fairly rare compared to things that are socially maintained. So when they do one of these standard functional analyses, they again, one by one, kind of test out these different functions. So whether attention's diverted or whether the parent's giving a lot of attention when a target behavior occurs, and they ask a parent, or if it's the provider themselves, they do these things to see what happens when I give attention to something, when I divert my attention, that kind of thing. And so they go across all of these categories and test these things out. And they usually do it in 5-minute segments that they call sessions. So this isn't like a therapy session. This is like a 5-minute segment that behavioral therapists oftentimes call sessions. So for example, here is a child where they were concerned about a number of dangerous behaviors, destruction, aggression, and self-injurious behavior. So that's what they were kind of tracking on this. And they were trying out these different potential reinforcers, these social functions. Okay. And so they did 18 5-minute segments to figure this out. So it is time intensive to get this kind of information, this kind of data on an individual. And as you can see, as they go on with this, what typically happens is a pattern starts to emerge. So in the case of this child, it was really those escape conditions when they were turning that on and off, where they really saw a lot of the dangerous behavior at a higher rate than those other conditions. So now they know they want to design an intervention that is focused on treating escape maintained behavior. So, and that really is the payoff, is that then you can develop a very targeted treatment plan. And hopefully, because it is targeted, then treatments can be a lot more efficient. So, for example, you read a parenting advice book or whatever, and they might talk about like selectively ignoring things or doing planned ignoring, right? When a child has some sort of disruptive behavior, you're going to turn your attention to something else. Well, if you have a child who has escape maintained behavior, that's not going to do a whole lot toward reducing that behavior that you're concerned about, because it's not matching with the function going on. It's a great strategy if you have attention maintained behavior, not so much with escape maintained behavior. So when you do this kind of assessment, you figure out just exactly of all those, many behavioral strategies out there, which ones do you actually need to be implementing. When we're working with individuals with autism, we're oftentimes doing this kind of assessment because we want to do a kind of therapy called kind of behavioral therapy called functional communication training, FCT. And the reason we're doing that a lot with autism is because this, as applied in the name, is an intervention that focuses on communication, appropriate communication, when there is a true functional communication deficit because of where the child is in terms of their language skills. And I didn't point this out too much last week because I was kind of flipping through quickly, but FCT really has the most evidence of all the function-based approaches in the kind of the behavior therapy realm. So we know if we can start to reinforce appropriate behavior at the right times, teach and train that, we can see a lot of progress in terms of the dangerous behaviors. Okay, so I'll just say a few words here. I want to kind of flip through these quickly so I can show a little video. But these are some just general guidelines. So, if we think the child's engaging in some dangerous behavior and the attention received from that behavior is rewarding to the child, then we're going to do a lot of things to minimize that attention for dangerous behavior, obviously, while still, blocking things and keeping everyone safe. We're going to work on providing the behavioral expectations really early on before there's any behavior occurring. We're going to be ending fun interactive activities if dangerous behavior is occurring. And we're going to have a lot of focus on behaviors that we want to increase through like letting the child specifically know what we like about their behavior. Thank you for using your gentle hands. I like when you're putting the toys into the box nicely, gently, those sorts of things. It's a tangible function. This means like we think the child's engaging in the dangerous behavior, and that results in access to preferred items or preferred activities when they engage in that behavior. So what we try to do is have the child demonstrate compliance or appropriate communication before they get that preferred thing. We work a lot on showing when a preferred activity or item is going to be available. So things like first then visuals, and also visuals to let kids know when something is not available. Even if they're engaging in appropriate behavior, sometimes we cannot go to McDonald's or have television all of the time, even if you're requesting that very appropriately. So letting the child know when that thing is available to them, and working a lot on teaching communication, appropriate communication to access an item. And if we think that the child's engaging in dangerous behavior, to avoid or escape things that they don't like, that they find aversive, first of all, we want to make sure that the task that they were asking them to do is an appropriate task. So that, for example, we have schoolwork at the appropriate level for this child and where they're at with their learning. We want to have a lot of breaks. We want to definitely work in like a first then or a work break system. We want to teach the client or patient how to appropriately request a break, and then reinforce those appropriate requests, especially at first when they're building up that communication, and then later on, really letting them know what work needs to be done, and then being able to request that break. We're going to intersperse easy tasks with things that are a little bit harder. And we're going to think really, really carefully about providing timeout or time away from an aversive situation if the child's already engaging in dangerous behavior, because that's going to reinforce that escape function. Okay, so this is just a little example of like one of those work break systems, right? First then systems. So this is a child who clearly is kind of farther along in terms of how many work tasks they can do to build up to that fun preferred activity. So it doesn't just have to be one task, and then, eventually we want it to look more like a work system. So with functional communication training, basically what this, we're using those principles there to reinforce an appropriate behavior or appropriate communication bit, I should say in this case, that they can do independently to get something that's reinforcing to them, whether that's tangibly something or attention or a break from the situation, right? That's their reinforcer. And with that, we are withholding those reinforcers when dangerous behavior occurs. And how a child communicates for that thing that they want is going to look different depending on the child and what their communication needs are. So some kids have picture cards or word cards that they can use. Some kids use a device like a Big Mac that verbally says the thing like, I need a break or I want a break. These are kind of dated. There's more, I just realized these pictures are a little dated. So there's definitely more tech out there and a lot that's integrated into devices now to aid communication. And for kids who have more verbal communication, more expressive language skills, then oftentimes it's prompting and reinforcing those appropriate words to get to that reinforcing situation. Okay, so I'm going to show an example here. So this is actually a child who has has tangibly maintained behavior, meaning they engaged in a lot of dangerous behavior to get stuff that they wanted and activities that they wanted. And so this is a little video showing kind of how FCT worked for them.
I want to play. Functional communication training. Tangible.
Prior to learning skills on how to respond to Cameron's behavior, We would have a child that had bruises all across his forehead because he would just get frustrated with wanting a toy and scream at the top of his lungs and headbang the floor. As a parent, it's very difficult not to give in because you don't want your child harming themselves. But it's very important to not respond to that bad behavior, because whether you respond good or bad, that just gives them more motivation to continue communicating that way. Use a communication device or PECs, and that's going to help you tremendously. There were some times when I wondered if my child could ever communicate with me. I didn't know if it was even in him. But after giving him more structure and forcing him to communicate that way, we've both developed a habit of using either a PECS card or a communication device. And you will be amazed at how much your child actually knows if you follow through with this.
FCT for a toy. FCT is often used to teach a child how to ask for a favorite toy or a favorite activity. Here are the steps to implementing FCT. A behavior assessment found that one reason Cameron engaged in problem behaviors was to get his favorite toys or other items. 4 steps were used to teach Cameron to use a communication system instead of his problem behaviors. You will use the same steps at home. First, let your child pick a toy. Have a toy or activity your child wants to play with. Your child may want to change the toy or activity during the session. You will want to notice if your child seems bored or doesn't want the toy. If this happens, offer a new toy or activity. It's common for children to want to change toys after playing with one for a while. Second, let your child play with the toy for about 2 minutes. When you play with your child, don't take away the toy or ask him to do something with the toy. You shouldn't tell your child how to play or what to do. Instead, just have fun with your child while playing. You can talk about what your child is doing by talking about the toy or naming your child's actions. Third, tell your child it's now your turn to play with the toy after 2 minutes of play. You may say, "It's my turn to play with it," or "I want to show you something with the toy." Fourth, ask if your child wants the toy back, and tell your child how to ask for the toy. If your child does show problem behaviors, stay calm. Don't talk about the behavior. Instead, remind your child about what he needs to do. Look for signs that your child is ready to communicate and wants the toy, such as reaching for or looking at the toy. Tell your child what he or she needs to do to get the toy. You may say, "Do you want your toy?" Say, "Play please," to get it. You may say, "If you want your toy, press the switch like this." Repeat the directions if your child does not ask for the toy within 5 to 10 seconds. Be positive with your child. After your child asks for the toy, offer praise like, "Good job asking," and give the toy back to your child to play with. Give a hug, a high five, or something else she may like. Show your child how happy you are with her good behavior. After your child asks for the toy, he or she may play with it for 2 minutes. Then you repeat the steps over and over for one practice session. Here are the steps to implementing FCT.
Okay, so it's going to go over the steps again. So we're going to go ahead and move on. And this is the treatment chart for the child that had escaped maintained behavior that I showed prior to kind of getting into the details about FCT. And so as you can see, they started with just like one task. And I think actually the task was like putting one toy into a bucket, and worked on, again, setting that child up so they could perform that behavior, reinforcing them with a break when they perform the behavior. And as the child got used to that system, then they started adding on additional work tasks. And you can see like they got all the way up to like 40 items, and then eventually like doing like a shape sorter. So not only just having to put them into a bucket, but sort them as they were putting them in. And so kind of once they got used to that system, even like adding on additional work tasks, the child was able to maintain safe behavior. Okay, now I'm going to move pretty quick on this PCIT stuff. I don't know why I got kind of talking about the behavior therapy stuff today, but I'll talk just a little bit about PCIT again, because it's popular in Iowa. This chart's a little bit old, but people continue to be trained in PCIT in Iowa, and it's available in a lot of communities where there might not be ABA yet, or people who are treating dangerous behavior, where there's like specifically people doing that for kids or individuals with autism. And PCIT is an old intervention, was developed probably about 60 years ago now, definitely 50. And it's parent mediated. It's 100% parent mediated, actually. So the therapist isn't doing anything but teaching and coaching the parent to run the treatment. And it was originally designed for young kids with disruptive behaviors in the 1970s. And this researcher named Sheila Iberg got really interested in authoritative parenting. Again, you might remember that from developmental psych, so balancing rules and structure with warmth. And she got really interested in the work being done by a psychologist named Connie Hamp, who was teaching parents about like planned ignoring, like I was talking about earlier, how to give directions, appropriate ways to praise, how to do a real structured timeout, and again, working with parents on these things, which was kind of novel then. And she added to that intervention model like ways to code things and ways to get data on things, so we could kind of measure over time if things were working. But the things that she was interested in was more kind of like the intensity of the behaviors or the frequency of the behaviors, not so much the function of the behaviors, like the things that we were just talking about. So this intervention doesn't really take into account function of the behavior. It kind of hits at multiple functions. So it's a shorter assessment period, but maybe a longer treatment period, because you are trying a lot of different things. You can certainly start to tailor it for kids based on what you learn and know about them, but that's kind of the difference there. A lot of research showing that it works well for kids with disruptive behavior. It's probably, I think it is the most researched intervention with young kids. And definitely the research indicates that it's effective. It's an intervention that's basically divided up into two parts. One where you're working with parents on a lot of the same skills that like a play therapist would use with a child. So lots of praise and reflecting and describing what the child's doing, imitating what they're doing. And then once caregivers get good at that, then you work on more of the behavior management side. So giving directions, how to follow through, if you're going to use timeout, how to do a highly structured timeout. I'm going to skip the video, but we'll have a link to this video when we send everything out on the webinar series. It's just a place in Michigan that offers a lot of PCIT for young kids with autism. That kind of gives you a sense of what it looks like. Okay. So people thought it would be a good idea to start doing PCIT with kids with autism and their families. for a couple of reasons. One is the beginning of the treatment, that first phase where you're doing a lot of play therapy stuff, looks a lot like the developmental interventions or the naturalistic developmental behavioral interventions that we know have emerging evidence or good evidence that they work. And we, just like we've been talking about, kids with autism are increased risk for disruptive behavior problems, ADHD symptoms. And we know that parent training approaches work really well in autism interventions. And like I said, it ended up that PCIT was disseminated so well here in Iowa that we ended up with these areas of the state where we had PCIT, but we didn't have autism services, or people were on long wait lists for autism services. And that wasn't just in Iowa and other places as well. So that's kind of the why of like why people were thinking, hey, we should give this a try. Now the evidence base of like, hey, does it actually work? They've actually done 3 randomized trials, and if you think about when we were talking about interventions and judging them, I think last week, the one that I gave it as an example, if they had at least 2 randomized trials, you were in pretty good shape, right? So they've done some randomized trials, and there's decrease in disruptive behavior. There's some people who have just in the first phase. There's some people that have looked at like severity of symptoms of autism, and think that maybe the back half of PCIT, that second phase where you're working on behavior management, the way PCIT does it may work better with kids who have milder autism symptoms. And there's lots of case studies and single subject designs out there as well, in addition to these randomized trials. Now, when people use PCIT a lot with kids with autism and their families, a lot of times they're doing some modifications. So they're adding in visuals, like a visual schedule for the session, or a social story, a social narrative. Maybe they're putting some visual labels on things to help with the prompting for where things go if you're working on putting things away. Maybe people are adding in more supportive prompting. So kind of traditional PCIT just uses a verbal prompt, but certainly gesture and physical prompts are options. A lot of people don't do timeout because there's concern about escape maintain behavior. So they do other things in terms of behavior management when they get to that second phase. Or if the chair itself if timeout is going to work, but the chair itself is somehow problematic from like a sensory point of view, they might eliminate having to use a timeout chair. Or sometimes people just stop after the child-led phase. Now, what I'll say is, because it got really popular in Iowa, people are like, oh, we just do this, because we have a lot of it. But there's a lot of reasons to think about, hey, even though we have a lot of this, let's make sure it's a good fit, and let's keep advocating for other things that kids need, like FCT or ABA if it's a skill deficit. Or maybe you really want to work on play and communication skills, and you're like, hey, this is a play-based intervention, I could work on those. Well, you can, but maybe an NDBI would be a better bet for that. You got to really be mindful of where kids' comprehension is at, and do they have enough language to be able to understand the kind of directions that are presented. Maybe it's actually social skills and those kinds of things that you're interested in, and that's a different kind of intervention. So even though there's a lot of PCIT and a lot of PCIT in Iowa, it's important to think like this is not the one thing, and we got to keep thinking about what's a good fit for the problem at hand, and what we need to advocate for on a larger scale. If you're interested in PCIT, there's actually been so much research and so much interest that they have a big handbook. It's an expensive book, but talk to me if you're interested in this, and I can see what I can find for you in the book. Okay, and last, a few words about safety, and specifically about elopement and wandering. There's oftentimes in the news, way too many times where kids have wandered, and particularly if, you know, they're interested in things like water and train tracks and things like that. It can be a very dangerous situation. This is an organization that does a lot of things, but they've developed a lot of nice safety products over time, not just for wandering and elopement, for other things too. So I would encourage you to take a look at their website, nationalautismassociation.org. They're known for the Big Red Safety Toolkit. If you've ever seen that, this is the association that developed that and has disseminated over time. You know, I just grabbed this flyer off of their website because I thought it was a nice summary of the kinds of things that we want to be thinking about. Certainly home safeguards and personal safeguards, when available, they can be very, very helpful. So, you know, different locking systems or home security systems, secure gates, those sorts of things. And oftentimes there is funding for these kinds of things through, in Iowa, the waiver system or children at home grants. Those kinds of things can oftentimes fund these items. Same with personal safeguards, and you should be checking with your county and your local police, city police, to see if they have anything in place for individuals who wander, tracking systems, or even just something very low tech like keeping on file information about the individual. And communities need to keep talking about this and think about, yeah, exactly, those kinds of papers that can be kept on file, and making neighbors aware of situations so they can be looking out for their child, for an individual's child as well. And teaching safety skills, figuring out what might trigger a child, those antecedents, right? And making sure that authorities are immediately alerted through 911 if someone's gone missing. And the general procedure is to check you know, creeks, rivers, lakes, those kinds of around those kinds of places first, because that is the most dangerous situation. Okay, so we have maybe just a minute or two for maybe one or two questions. I'm sorry I didn't save much time for questions today. You can certainly email me as well. Or if you have a burning question about this kind of stuff, we can talk about it next week too.
Thank you, Kelly. I did have one question that was submitted prior to today. It was, does elopement in children with autism stay stable, get worse, or slightly better with age?
Slightly better with age. And I do think the biggest concern is for individuals, regardless of age, that have intense interests in water, because that, again, that's a very dangerous situation.
I have a comment in the chat box that says, thank you for this session. I have so many questions, but I can't quite get them out yet. Thank you for joining us, Christina. We will be sending the recording link out, and if you have any questions, you can feel free to respond with those, and we'll make sure we get them answered. But thank you all for joining today, and thank you to Dr. Pelzel. We will see you next week for the session on school programming.
Thank you.